Hi, good evening, everyone. Welcome to this session on Vejon with regards to COVID-19. This is an unusual setup, and it's one that I've only put together quite late because I'm actually having a Zoom conversation with a number of people talking about COVID-19, autoimmunity, omicron, and where the pandemic is likely to head in the next year. Now, you'll have to bear with me as I will be flipping between screens, and I hope you're hearing me clearly as I'm going to be using a Zoom presentation to handle this conversation, and I'll be flipping back and forth in between the presentation so that you can interact or see the interaction with some of the people that I'm speaking to who may have questions afterwards. So,
Dr. McMillan,
yes.
I can hear you on the LinkedIn Live.
Excellent, wonderful. So, in order to, Jackie, do you mind just checking?
He shared with us last year, and it was extremely impactful and educational. So he's agreed to come again and to share with us some updates on COVID-19. So excuse me, Ruth, sorry. I just need to interrupt you for 1 second. Dr. McMillan, there are comments coming through on LinkedIn that there is no audio there.
Yes, I think I've fixed that now. I think that should be
Okay.
coming through now. And I think
Sorry
they'll
about
hear at the moment. So, sound is back on. So, great. Thank you very much, Ruth,
Sorry.
for introducing yourself. And Ruth, can I just start doing the presentation? And then
Yes.
we'll have some
Yes. So
questions afterwards.
yes. So we just invite people, if there are questions that you have, you can put them in the chat. And after the presentation, the formal presentation, then Dr. McMillan will be responding to the questions that we have.
Wonderful.
Sound is off on LinkedIn.
Its sound is off again.
Mhm.
That's unusual. You're not hearing it again?
These are comments coming through on LinkedIn.
I think it should
It's
be.
buffering, so maybe it's just a question of a delay.
Yeah, it may be a bit of a delay. So, just so that people are aware, what I'm doing is I'm using two systems together. It's the first time I've tried to do this, so you have to bear with me, just so that I can share some of these ideas. So, what I'm going to do is I'm going to flip over to my other system, and just give me 2 seconds, and your sound will disappear, and then I will put it back on. So, just hang fire. Excellent. I think you should hear me again now. And I think I'm ready to go. So you can see my screen. Ruth, do I need to put my spotlight on?
Not see a screen. We're not seeing a screen. You can share. You have to share
Yes, no, what I
now.
mean is you can see me. Okay, and you can see me
Yes.
speaking.
Yes.
Wonderful. Great. Thank you
Okay.
very much for the patience from everyone. And here we go. So, this is a presentation about breakthrough infections, future of COVID-19. Based on my research, a lot of interactions that I've had, certainly on social media, giving me a few ideas as to where we are and what is likely to happen in the future. Very important for me to share this disclaimer. I am sharing some of my research. None of this represents a specific medical advice. Everything that I say, you can certainly challenge and rebut. And I'm just sharing some thoughts so that this is clear to everyone. Thank you very much. Okay, so the areas I'm going to try and do is I'm going to do a refresher on autoimmunity. I'm going to speak about the characteristics of Omicron. I'm going to share about breakthrough infections, and then we're going to summarize with some of the potential challenges that we have in the future. And so, this is the principle that I'll be focused on for this presentation. For people who don't know, I started in 2020, in April 2020, focused on COVID 19 being a viral mediated autoimmune disease. And that's a very important starting point. And I can say categorically that almost everything that I have seen so far, in terms of the disease, in terms of what we're seeing, fits within the paradigm or the umbrella of an autoimmune disease, even with regards to our treatments, which would primarily be steroids at the moment. And so the first thing that I have to do is help people to just refresh them about that basics of autoimmunity. So the first thing that you have to remember is that an autoimmune disease tends to occur where the body attacks itself. You have very specialized tissue in the body that produce antibodies. There is secretory IgA, and I'll come back to that in a little bit. But the important thing is that plasma cells produce antibodies, and these antibodies can attack different organs in the body. It's not just antibodies that are part of an autoimmune disease, but the antibodies are a central part to the way how an autoimmune disease works. And in terms of COVID 19, it's absolutely important to grasp this concept. So I'd like to take a few minutes just to break down some of the simple observations or the simple principles about the science when I speak about autoimmunity. So I will start with some basic things. The virus, as we know, enters the nose. It tends to bind to specific receptors in the nose here before it will spread down into the lungs. And it's when it hits the lungs that we have lots of the disease that people know when people are short of breath. And when the virus goes into the nose, it binds to a specific receptor here. And this receptor is not there for the virus. It's an enzyme. It's ACE2, which is just a normal part of cellular function. And actually, in the nose, there are very high levels of ACE2. And this is just part of normal blood physiology. The virus binds to it, however. It's kind of like a burglar using a special key. Using this, it enters into the cell, then replicates and produces multiple thousands of viral particles, which then spread to other cells, and then the virus then spreads throughout the body. And that's essentially the principle with regards to what happens in COVID 19. And actually, this is what happens in almost any viral infection. The principles are all the same. ACE2 is very important to understand. And this is the bit that I'll then go back to in terms of showing this slide. So, what is ACE2? So, it's primarily the enzyme that is used, and you can see here the virus. This is the virus here, this circular structure. You see the spike protein on top, and the spike protein is like the key. It attaches to this lock, which is ACE2, opens the door, gets inside the cell. But ACE2 is normally used in the body, part of what we call the renin angiotensin system. And this system inside the bloodstream, at least, helps to regulate blood pressure and inflammation. And so it's a normal physiology. It's just that this virus uses it to get in. And to keep it into context, when we think of something like MERS, MERS uses a different virus. So MERS is the Middle East respiratory virus, which was another one of the coronaviruses that caused an epidemic in the Middle East in about 2012. And that virus doesn't use ACE2. That virus uses a different enzyme, a different receptor called DPP4. And all viruses will find a protein on the surface of a cell to use it as a trick to get inside the cell. And that's the system how viruses work. So, within the context of a viral mediated autoimmune disease, why do I think that occurs? And the first piece of the puzzle to grasp in order to understand it is something called serum ACE2. Now, this is something that I wasn't aware of, and it was only very early on in the disease. And I'll take this off just for a moment. I'll tell you this point. When I started researching in about February 2020, and I thought, let me try and put some thought to what's going on here, I needed the information to come out of China. And one of the very first papers highlighted something that stood out to me as an outlier. 76% of the severe patients had hypertension, and there were no children. And that to me was very strange because a virus wouldn't normally target any specific group. It just targets everybody: children, adults, infants, everything. And this was unusual with COVID-19. So I immediately started to look for a connection as to what characteristic physiologically in the body would affect adults with hypertension and not affect children. And that's essentially what I started to look for. And it's a principle that I use in research called outliers research. And this is what essentially I found. I found there was a thing called serum ACE2. Now, I didn't know about this before. I'd heard of serum ACE, but not serum ACE2. So serum ACE2 occurs inside the bloodstream. So this is a blood vessel here. These are the cells lining it. This pink area is the bloodstream. And here is the ACE2 attached to the endothelial cells, primarily in lungs and kidneys. And what the virus would do is also bind to this and infect these cells lining the blood vessels. And this is how it spreads around the body. And when we find viral particles in the intestines or in the liver or wherever, it uses the bloodstream. However, in some people with certain comorbidities, this ACE2 gets clipped off and you have serum ACE2. So this ACE2 is now floating in the bloodstream. And the way to think about it is that if you are young, almost all of the ACE2 will be attached to the blood vessels, like 100%, maybe 98%, and 2 are floating in the bloodstream. But if you are older with high blood pressure and certain other comorbidities, you may have 40% of it. I'm just picking a random example of serum ACE2 with only 60 attached to the blood to the cells. The reason this occurs is not absolutely clear. We think that it probably is more to do with a counter-regulatory mechanism as people get older and they have hypertension or heart disease, and the levels of angiotensin 2 in the blood rises. The body does a counter-regulatory mechanism where it therefore needs the ACE2 not just to be attached to blood vessels in the lungs, but to go into the bloodstream, and I'll show you again, and float in the serum and manage angiotensin 2. So this level rises. Now, this is also the serum ACE2 that can bind to the viral spike protein, and I will come to that in a second. But here is an important point. Serum ACE2 is elevated in these groups of people: males, certain racial groups, East Asians and Africans, in people with obesity, diabetes, older people, hypertension. These are all the conditions that are associated with elevated serum ACE2. So the question is very simple. If the virus uses ACE2 to enter cells, In theory, if you have high levels of serum ACE2, it will do one of two things. It will either block the virus or it could make the disease worse. And based on the characteristics of people who end up with very severe COVID 19, this fits perfectly. Men are affected 60-40, so meaning 60% of deaths are males. There's no other condition does this happen in. Obesity in younger people is huge, and in terms of is one of the most important risk factors in younger people. Certainly diabetes, older people, hypertension, and heart disease. These are all conditions that are associated with severe COVID 19. So, based on even that very simple principle, to me, ACE2 or serum ACE2 is central to severe COVID 19. And this is what led me to the principle of autoimmunity. And this is just the basics I'm highlighting. And this is a schematic as to what it was that I thought and saw. Essentially, the virus here with the spike proteins, when it gets into the bloodstream, the serum ACE2 will stick to the spike proteins. And we know this happens in research because this is how we check to see how well ACE2 binds to the spike protein. This will then happen. So you'll have very tightly bound serum ACE2 to the spike protein, multiple ones stuck onto the surface of this virus. And then when the immune system picks up the virus and then tries to break it down, because what the immune system, what this macrophage will do, is take this whole virus and chop it up into little pieces and then make multiple antibodies to target it. So the question is simple. How will the immune system know the difference between the spike protein and the serum ACE2 that is very tightly attached to it? And so what would then happen, based on our research, is that the body would produce multiple antibodies that target the virus, but also ACE2. ACE2 floating in the bloodstream and ACE2 attached to cells. And that's the essence of what it is that we've said since April 2020. It's an autoimmune disease that occurs in people with primarily specific comorbidities. And the data from the CDC very strongly suggests this because 97% of patients who died with COVID 19 had at least one comorbidity. We've never seen that before. And as I said, 60-40, 60% of deaths were males. Why would that happen in a viral infection? And so that's the basis that I've come from with the research. And as I said, it answers to me almost every question, every pathology, everything that I have seen so far in COVID 19 fits perfectly under the umbrella of an autoimmune disease. And so that's the basis of what I've done. So as we move on in the conversation, and I can come back to that if there are any questions about it, that's to set the stage for where we are now with regards to Omicron. And Omicron is unusual, to say the least. When we compare it to the Delta variant, which was already quite a significant variant, all the red spots on this show mutations that are different from the original virus. And so this here is the Delta. And the Delta was I guess, the most infectious and probably the most lethal of all the variants so far. But look at Omicron. This is a beast. It has so many viral mutations here. It's unbelievable. We still don't quite know why it took such a line. It literally jumped, it did a quantum leap away from all the other variants. So it wasn't a follow-on of the Delta. It just literally appeared out of nowhere almost. We don't know if it's necessarily South Africa. South Africa was where it was first found and isolated. And it's because they're doing a lot of research on looking at viruses, why they probably saw it first. They were probably punished for identifying it, and that's not a good thing. So hopefully there will be more cohesion across the world when it comes to dealing with some of these things. The characteristic about Omicron is just to do with how contagious it is. And this was very early on in the Omicron wave, and we could see all the other waves here, which is the alpha, the beta. This one here was the delta, which had a bump towards the end, and they all tend to follow a similar trajectory in terms of reaching a peak. But goodness, look at Omicron. This one here was just flying out of the blocks. And it was very, very relevant. And I think that in terms of this is what happened in South Africa compared to the other waves, this is almost a straight line up in terms of how many people were affected in terms of the Omicron wave. And in reality, it could even have been higher than that, because in South Africa, they may not have been testing as much as they are in some of the first world countries. So if they had been probably testing more, that was incredibly infectious. The question is, how in the world is that possible? And here is an image of what happened early in the pandemic. So this was early December, just after they found in South Africa. Within a short period of time, it was already in the United States, Canada, and Europe. There are a few cases detected in Brazil, Saudi Arabia, Australia, and India. And this was early December. The next slide is actually the 26th. And this was from the New York Times. This one here is also from the New York Times on the 26th. And that's where it is. It is now literally almost across the whole world, except certain parts of Africa, maybe a little bit of Central America, but it has spread within a month and a half across the whole world. It's extremely contagious, and it's almost unstoppable when we think about how well it can spread as a virus. And that's important because it impacts what we would therefore be able to do with it. So I'm going to take you back to some very basic principles about viruses and how viruses work, because I was trying to understand what is different about Omicron. And so I have here again this slide showing how the virus enters the nose, binds to ACE2, and then spreads down into the lungs. Okay? This is the ACE2 receptor that it would bind to, but that's a very simplified entry mechanism. It's actually a little bit more complex than that. And so I'm going to take you into a little bit of what the research I've been doing over the past few days in preparing for this. So you have to bear with me with regards to some of this. I'll try and take this slowly because I was fascinated by it. So I hope you will be as fascinated by it as me. So here we go. The virus uses two entry mechanisms. Okay. There is this one. I call this A, and this is B. So this is probably a little bit too small, so I'm going to make it a little bit bigger for you. So here we go. In route A, we can call it what we call endosomal entry. The virus binds to ACE2, and then it has to find a very specific other protein on the surface of the cell called cathepsin. When it binds to that, the whole virus is pulled inside the cell and it gets a lining around it. And this is what we call an endosome. So the virus tricks the body and slowly gets inside to the cell, inside a bubble, and it's still inside the body. It's then taken inside, and then this endosome, I think it has the acidification of it increases, and then it releases the viral particle. This viral particle here, this is the RNA, will then make thousands of copies. It just takes over the cell and starts to replicate. And this is route A. The thing about route A is that it's relatively slow. It's not quick compared to route B. Route B is cell surface entry. Okay? And here this time, it uses a specific enzyme called TMPRSS. So the virus binds to ACE2. This then attaches onto the whole complex and clips it so that straight away the viral particle is dropped inside the cell. It's a very quick mechanism. The alpha, delta, beta, and the original virus all use this mechanism. and they would all get into the cell very quickly. They would then hide from the immune system, which is interferon, so that it could spread very quickly to the lungs. And then that's where it caused problems because it would get to the lungs before the body even knew. And the principle I usually say to people is that this is why you don't even get a runny nose usually in the original virus. In a cold virus, which is also a coronavirus, the interferon switch is not able to be done, so you get a runny nose, the body tries to fight it off. With regards to COVID-19 or the SARS-CoV-2 virus, it gets in quickly, replicates quickly, spreads quickly, and the body doesn't know, so you don't even have a stuffy nose. And that's the system that the virus has used to spread. So let's get back to this picture a minute. All the other viruses used this mechanism to get inside the cell, except Omicron. Omicron uses this mechanism. It has completely flipped around its entry mechanism to get in this way. It's almost as if it knows that this route is blocked and it's using this route instead. Now, it's unclear why the virus would do that. And it raises the question as to whether or not some people would argue about immune pressure, that maybe there was too much immune pressure because of, as we are doing vaccination, that's a speculation. And so therefore the normal mechanism was no longer effective. And we selected viral particles that used plan B or plan A, which is the endosomal entry. And it could explain why the virus 1 is able to infect so many people, because what they've found with the Omicron particle is that it binds more strongly to ACE2. So when it binds more strongly to ACE2, and it has a mechanism that can attach to more cells, because cells that are in the sinuses also have ACE2 and cathepsin, and so it can actually therefore infect more cells, but the spread is slower. And it may be part of the reason as to why the virus doesn't infect the lungs as well. And this is one of the things about the virus, is that we've called it more of a mild infection, which can be a dangerous concept. It is infecting people, it is spreading. However, it's not as effectively getting to the lungs. And part of it may be because of the entry mechanism. Part of it may be because it may not be as good at suppressing interferon, because interferon is the signaling protein that blocks the switches off the cells from making protein. So if interferon is produced, the normal cells know there's a virus around and they just switch off the lights effectively. And so the virus can't make new particles, it slows it down, and it gives the immune system time to come on stream and fight the virus. But SARS-CoV-2 has been extremely effective at getting beyond that interferon mechanism. And part of the reason in terms of Omicron may be that it is now using a completely different entry mechanism, well, a primary entry mechanism than it was for the other variants. Here is the reality of what is happening now. So here is BA1, which is the Omicron variant, which is spread, as we said, across the world. But guess what? We've got BA2. This one is even more infective or more contagious than the very contagious Omicron. This variant looks without a shadow of a doubt that it is going to take over the BA variant of Omicron. Extremely contagious, already spreading through Europe and the US and South Africa. And this one is also going to be unstoppable. What does it mean? It's difficult to tell, because at the moment, one of the hopes is that the Omicron variant is so contagious that it prepares the bodies like a natural vaccine. The problem is that if Omicron was already so contagious, how can we have another Omicron still reinfecting people? That doesn't make sense. So there's a lot that we need to understand in order for us to get a good grasp of where things are. So This is an important point with regards to the immune system. And this is me now shifting into explaining something very, very important about how the body actually fights respiratory viruses and why it's so important about natural versus probably vaccine immunity. There are a lot of questions that we need to understand, and the truth is that we are not absolutely sure, but science is hoping to get more answers. But here is the basics of what happens with a viral infection. When the virus comes into the nose, the immune system functions in compartments. And this area, you could call it the upper airway, is an immune compartment. And it's very specialized with dealing with viruses, cold viruses, flu viruses, RSV viruses. And what it does is that it produces a very special kind of antibody called secretory IgA. And secretory IgA is different from the normal IgG antibodies that are in the bloodstream because it attaches into mucus, it then grabs virus, and most importantly, it doesn't create an inflammatory response. They're usually very high concentrations in the mucus and the saliva, and as I said, it traps the virus. This is very important. Now, secretory IgA is only on mucosal surfaces, which is gut and upper airway, and I guess in the lungs as well. And you'll also have secretory IgA in, say, for instance, vaginal secretions. So it's an important mechanism that the body uses to fight viruses and bacteria. And really critically, as I said, the fact that it doesn't usually trigger an inflammatory response is very important because what it means is that it will just stick to the virus or the bacteria. It will get trapped in the mucus, and as you sneeze or cough or spit, it gets taken out of the body and it's unable to cause more infection. And so, this is the basis of how the body functions with mucosal immunity. And one of the very interesting things that we had found is that there are some people who are almost resistant to COVID-19 in that they face multiple variants, they don't seem to get any kind of infections. And it probably is because they faced a normal cold virus sometime in the past 2 or 3 years, and they still have mucosal immunity that recognizes pieces of the coronavirus, which it then uses to help to fight it off. So here is another slide showing how the secretory IgA in nasal secretions or in saliva, it will have multiple epitopes on it. So it could bind to the spike protein, it could bind to the side of the spike protein, it could bind onto here the envelope protein or the membrane protein. So there are all these proteins on the virus. It will attach to many of them, and then the virus can't infect a cell and gets taken out in mucus or in saliva. As I said, it works for both viruses and bacteria and it neutralizes them. It's a very sophisticated system. So the question is why is that important when we're even talking about vaccines? Why is it that I keep on talking about mucosal immunity as being a critical part of what we do? So here is the reason. When you get a vaccine, the vaccine is injected into your muscles and into the muscle, in the deltoid muscle. It then triggers a response, an immune response, and produces IgG antibodies. In this image, I've colored IgG as being orange red. IgA is green. So the levels of IgG in the bloodstream rise very quickly. There's a problem though. The IgG is in the bloodstream. It's not in the mucus. Only a small percentage of the IgG, and in some studies it suggests only about 1%, will actually go cross the mucosal barrier to be in secretions. And this is part of the reason why it does help early in after vaccination to block infection. And I'll show you the slide again. So this is early stage, very high levels of serum IgG, leaks into the mucosa, so you have some IgA, not a lot, you have a good amount of IgG, and it's able to probably bind the virus. And therefore, it had an impact on infection. But it didn't stop everyone from getting infection, but it reduced transmission and infection. But later on, months down the line, and in some places, 2 months, 3 months, you suddenly have much less IgG because the serum levels are falling. And so you have less IgG leaking into the secretions. Suddenly now, it's much more difficult to bind virus. And so after months, a few months of having the vaccine, you would then have situations where some people are more prone to then getting an infection. And it's just really down to the levels of serum IgG spilling into the mucosal secretions. And this is part of the reason why we probably see an effect with regards to the boosters. The boosters increase the serum levels by, up to 10 to 20 times. So really high levels. So you therefore expect more to leak into the secretions. And so that would be an important mechanism to try and see if we could block transmission. But again, we would have the same problem. And the problem would be, again, early stage, high levels of IgG with a weak secretory IgA. It blocks virus. This is a later stage, low numbers of IgG leaking into secretions and still low numbers of IgA because the vaccine doesn't stimulate the IgA response. But then when you compare it to natural infection, that will have a very strong secretory IgA response. And that's the primary response that the airwaves would use to try and neutralize virus. And it's certainly evident when we look at the research that people who have had a natural infection, I think, and now the CDC are acknowledging that natural infection is more effective than a vaccine immunity, but they still think that you should get a vaccine along with the natural infection to what we call have super immunity. That's to be questioned, as we don't really have the evidence that doing that will improve secretory IgA responses, but it is what we have been told. And we really need to study that more carefully and ensure that this actually improves the resistance that someone could have to infection. Um, I've mentioned this here, the entry mechanisms again. And I will highlight these entry mechanisms again, because one of the problems is that when you then have an IgG or even an IgA response, it may be primarily targeting this aspect of the entry mechanism to try and block it. But when the virus has done this evasion and is using this entry mechanism, it's much more difficult for antibodies to block it. Without high levels of secretory IgA to stop it from binding to ACE2, it's very difficult to stop it using this slower entry mechanism to get inside the cell and still cause infection. And so this is probably one of the main reasons why we have a problem where Omicron is able to evade many of our vaccines, even booster vaccines. When we look at what's happening in Israel, it doesn't bode well for fourth or even fifth doses of a vaccine. So Israel are currently at booster number 2, which is 4 doses. And it's possible that we could continue using 5 and 6. But we really need to pause and think carefully about whether or not our current strategy is the strategy that will take us out of the pandemic. So I think that's about the total bit. Thank you very much for the opportunity to share some of this research and some of these thoughts with you. And I will try and see if I would be happy to answer some questions. So before you start asking anything, Ruth, I'm going to switch over my screen again so that the people who have been listening on social media can also hear some of the questions. So again, just hang fire for me for 10 seconds. Let me just get this swap. Okay, I think we're ready. So thanks,
Yeah.
Ruth.
Okay, so really that is just so informative. And I know it is a lot of technical terms for a lot of people who are not necessarily in the medical field, but I think you've really given us some major insight. I really just wondering if you could go over those two entry points again, really just explaining to us what is the difference between the two entry points, because I think that is a really critical understanding of how these variants are working. Could you take
Yeah,
us through that,
yeah.
please?
Do you want me to use the images again?
Yes, please.
Ooh,
Yes.
all right. I think I'll have to switch over again. I'll I'll switch over again and come back. I think it will be
Yes.
useful for people on social media again. So I'll quickly switch over again and I'll be able to take you through. Okay, all right. So you can see me again. So I'll
Yes.
now get that principle up again, and I will show you the big slide that would help to get the entry mechanisms in. So let's start off again. There are two routes that the virus will use to enter the cells. This route is a quick route because the virus binds to ACE2, that's ACE2 here, and there's this enzyme called TMPRSS, I hope I pronounced it correctly, and straight away it clips the spike protein. And once it has done that, it's almost like it does a flip, opens the door, and straight away the uncoating of the RNA is right inside the cell. Okay? So, very quick mechanism to get the virus inside the cell. And so, this is the main mechanism that all of the previous variants had used. Okay? And because it's faster, it will always outcompete this one. This mechanism is slow. Because this mechanism, it has to bind to ACE2. It kind of floats along on the surface until it meets one of these cathepsin proteins, and then the whole virus is taken inside the cell. So it then ends up with a piece of the cell membrane around it in an endosome. And this endosome then has to float in. Then it has to be acidified. That means that the acid level has to be increased. When it has done that, it breaks down the envelope protein and then it releases the viral RNA. So you can see between the two mechanisms, this one is quick, this one is much slower. Now, the virus has now, through Omicron, primarily used this entry mechanism instead of using this one. And truthfully, I can't think of any good reason it would do that except immune pressure. Because why would this quick mechanism be swapped to a slower mechanism if this mechanism could still work? I mean, the viruses can't think, they just do. And so it must mean that we selected this mechanism. So this, because you would have had viral particles that would have used this, but they would have been outcompeted by the viral particles that do this. These would have produced viral particles faster, spread to other cells. This one would have been slower and not as effective. But now with Omicron, with it using only this pathway largely, it has evaded the ability of IgA to block this. And so, therefore, this is probably the main reason why this virus, this Omicron, is able to get around everything. Critically, one of the interesting things that I'll share is that, believe it or not, this is where hydroxychloroquine actually may be useful. Because what it does is that it prevents the acidification of these endosomes, and so therefore slows or stops the ability of the virus to release into the cell. So strange as it may seem, we may find that Omicron could be sensitive to hydroxychloroquine just because of the fact that it uses this endosomal pathway as its primary pathway. That's a little bit controversial and something that we don't have a lot of evidence for. I'm just saying that it does open that option to think about and to research. Will you
Okay.
need me to show any more slides? So I think my audience can probably hear me, so I don't have to show you, and I can answer the questions and repeat them as they come up. So go ahead, keep on going,
Okay.
Ruth.
Okay. So Angela has a question here. Do you believe that 5 days are adequate for the quarantine period? And she says, thank you for sharing their wonderful information.
Well, that's not my call. I certainly don't control the decisions on that. However, I guess the question is, will the average person have cleared the virus in within 5 days? Um, Based on what's happening with Omicron, and I think that we have to think very carefully about when people are infected. It seems that the incubation period is much shorter with Omicron. It's about 1 to 2 days, as opposed to about 4 days with Delta. What we don't know is how quickly people clear it, because it's using a different mechanism. It doesn't seem to be spreading to the lungs as well. Um, and I think we don't know. I think that decision was based around need, because they would only have done that if they had a choice. I think that the decision would have been it should be longer, maybe 10 days as normal. But they're in a situation where they can't afford for healthcare staff to be out of work for such a long period of time. And I think it was more of a pragmatic decision. And it's a no-win situation. What do you do? Do you prefer to have not enough staff on the ground? Or do you hope that the majority of people have cleared the virus by 5 days? Whether or not we should worry about Omicron spreading because it's so contagious is another question. And this is what we're seeing in some countries where they're just saying it's impossible to stop, then don't try and stop it.
Okay. And someone asked the Sandra, Sharon, what is the name? What is the name of the next variant? And probably you could tell us a little bit more about that. Is that using the same path as Omicron, or
It is an Omicron variant. It's a slight adjustment to some of the receptors, but it seems to have created an even more effective or more contagious version of Omicron. So Omicron, the first one is BA1. This one here is BA2. What we are not sure about is, does it reinfect people? Because Omicron was so infectious that it spread across the world in a very short period of time. That would have meant that it spread in vaccinated, unvaccinated, everybody. If BA2 is more contagious and spreading even more quickly, then it's a strong suspicion that it's spreading in all groups as well. But then it would raise a question. If we have just had people infected with Omicron, why would BA2 still be able to infect people? And that's a
right?
really important question. It doesn't normally work like that. Normally, if you were infected with a virus, a cold, you would not get another cold within a month. It would take you, your immune system would have battled it. So we really need to ask some very hard questions as to whether or not the immune system is functioning efficiently within the context of Omicron? A really important question for which we don't have an answer yet.
And just following on that, before I ask the next question, you mentioned that the IgA one, IgA and IgG and IgA. So, and with the vaccine, you're getting more IgG, but
Yes.
the IgA is really working against the mucus version. So, is it that with Omicron, it's the IgA that is really blocking it more than the IgG? That's why the vaccines are. are not
as
having as
effective.
much as
Yeah, so
impact.
one of the first questions that we're going to have to try and clarify, but some of these questions are quite political. In that the first question is, if you have someone who was unvaccinated exposed to to the previous variant, when they are faced with Omicron, will they then have another infection? Are they better protected than somebody who is vaccinated against Omicron? A really important question. And because there is so much politics around what we do, I don't think people want to ask these questions. Because at the moment, we have a booster campaign, which we are encouraging people to get boosted. And the reason we're encouraging is that is because it protects against Omicron, or so we would think. But there are many scientific questions within that really, really need to be answered. Could we be impacting on the natural immunity? So, what happens with regards to the IgG? As I said, if you have very high levels of IgG and it's being secreted into the mucus secretions, does that inhibit the production of IgA? It's a really simple but important question. Meaning, if we tested the secretions of people who had been boosted, would we see lower levels of IgA than we would in somebody who had a natural infection? Would it just be very high levels of IgG? Because the problem then becomes, if the IgG has been evaded or is ineffective at blocking Omicron, that could explain why people are still getting the infection.
Okay. And another question here from Lily. At what point may it be too many vaccine boosters? 4, 5, 6, 10?
Yeah, well, this is another important question, and again, it's a scientific question. Um, I've said this before: is that to need 4 doses of a vaccine in a year is a worrying sign to me, because we should naturally question: are we actually doing the most effective mechanism to manage the disease? Okay. And that's a very important question, because if we don't step back and think carefully, and this is why I said, from my perspective with the research in terms of an autoimmune disease, it makes perfect sense to me, is that if we continue to use booster doses, we're not going to see an impact, because it's a viral mediated autoimmune disease. So if we don't improve the mucosal protection, that's at the nose level, we can't stop the virus. And so, one of the things that I've always said is that if we're going to use injectable vaccines, we have to use it in conjunction with nasal or mucosal vaccines. That's where we spray the virus or particles of the virus into the upper airway to trigger the immune system. That may be the only chance we would have of stopping variants like Omicron. And even then, we're not guaranteed that it would do that. So we would then have to step back to the original question, which is, are we just better off with natural immunity?
I jump in here just to throw in a question from the LinkedIn group. Someone has asked, what about the role of vitamin D deficiency?
Yes. Yeah, vitamin D is really interesting. And the more I look at vitamin D, the more I think to myself, we have made a huge error. But if we had spent as much time telling people to take vitamin D, as we have with regards to boosting and so on, I think we'd be in a different place with regards to the pandemic. Here's an interesting thing that I found about vitamin D. So, vitamin D has so many effects on the body, okay? But one of them that it does is that it has an impact on how the body attacks viruses and bacteria. I've forgotten the name of it. Was the first time I read it just in the past week. The body produces its own antiviral and antibacterial product. Okay? It has this specific protein that literally punctures the viruses and bacteria therefore killing them. Okay? Guess what is one of the critical pieces of the puzzle that will allow the body to produce this own antiviral, antibacterial? Vitamin D. So vitamin D is an essential step in terms of even our own immune systems. And for people who are living in temperate climates, who are darker skinned, absolutely need to be taking very good quantities of vitamin D. You have to remember, vitamin D, even when you are in the warmer climates, you can only get vitamin D from sunlight if you're not covered, one. Two, between the hours, I think, of in 10 and 3 at certain points in the year, because the sun has to be at a certain angle in the day and in the year in order for it to be effective for light to produce vitamin D. And so this is why, if anyone is in a temperate country, you absolutely should be taking a vitamin D supplement. And if I was going to make any point to anybody, a very simple strategy that we all can do is get vitamin D and make sure we're supplementing adequately. Some people say 2,000 international units, some people say 4,000 international units. You can do your research, get some advice on it, and just make sure you're getting vitamin D.
So, okay, along with that, is there any other supplement or any other nutritional, you know, means that we can help to build that
Immunity?
Like you've really highlighted this.
Vitamin D, yeah. I mean, there are lots of things. Vitamin C is a ubiquitous agent. It's another one of those very broad immune mechanisms. The body needs good amount of vitamin C in cells to fight infection. So vitamin C is also very good, very safe. I think vitamin B, niacin, is also very important in terms of helping to fight infections. So some people say things like quercetin. I don't know a lot about it. But again, anything that helps your body to fight a virus, anything that increases the antioxidant levels in your body would be important. But I always advise people, everything in moderation. Don't go taking too much of something. And if you do, make sure you take a break. So if you take something for 2 months, take at least 2 weeks off and then start again, just in case you're taking too much of it. That's the simple moderation principle that I have for anything, because it's quite possible that you can overload it. Somebody asked about selenium. This is on my. You can't see these questions here, but there are lots of questions coming in. I don't know, quite honestly, but I do know zinc is important. Zinc is an important part of the body fighting viruses. Again, there's lots of information out there about some of the very simple things we can all do in order to try and reduce the chance of an infection. But let me say something, Ruth. At the end of the day, while we're talking about fighting an infection, just remember the most important factor for severe COVID-19 is a comorbidity. We need to all be exercising more. We need to be all focused on our weight. We need to all know, if you've got high blood pressure, control the numbers. If you've got diabetes, manage it carefully. These are all mechanisms that we can use. If we are obese, go on a diet. This is the fundamental of health. And it's very sad that we have not spent enough time emphasizing that for everyone. This is just a no-brainer. This is what we all should be doing.
Okay. That thanks a lot for that. Okay, Sonia is asking, I noticed that the nose seems to be the main entry point for the body. Would you recommend that, along with good hygiene, blocking entry of the virus to the nose is an effective method to avoid infection, or am I mistaken?
Well,
that's where masking. I don't know if masking helps there.
Yeah, well, the thing that people argue about masking, it's one of those things that is so simple to do. I mean, there are some people who are claustrophobic and can't do it. That's fine. But the principles are very simple with a mask. it impacts on the aerosol spread. So if you have on a mask, it doesn't go as far as if you don't. If and so therefore, a mask is a simple mechanism to have a reduction on aerosol spread, but it doesn't stop people from getting infected. Nasal hygiene, there is a lot of information out there about this. Some people use, I'm trying to remember, povidone iodine. They're quite. I remember having a conference where people were using some very simple strategies of nasal hygiene in order to reduce the risk of the virus. So nasal hygiene would be equivalent of getting a cold, producing lots of mucus and blowing out the virus. It won't hurt. I don't see, as long as it doesn't do any damage and you don't do anything strange by putting anything strange in your nose. I can't see why this wouldn't be a good practice for us to do, like brushing our teeth.
Okay. And Charlene, I think you have answered this already. Does it mean that the other potential variants will use the endosomal entry? I think that's
Well,
said before.
It would suggest so, because the virus's aim is to spread and spread effectively. That may be a blessing and a curse, in the sense that the endosomal entry point is how the virus can evade the antibodies and so on. But it also seems to mean that it's less likely for it to get into the lungs. And that's where it's lethal, when it spreads to the lungs and then causes spread into the rest of the organs of the body. And so, in that sense, maybe that's a good thing. But truthfully, time will tell. We're at a point now where we now have to watch very carefully as to what happens next.
Yeah, okay. And Sharon, would these variants continue to multiply? Would the virus end anytime soon? That sounds like someone frustrated.
Yes,
and
yes.
Does science know where these variants are coming from?
Oh boy. Yeah, so I don't want to answer where the variants are coming from. All I know is that Omicron looks very strange. And if we have produced Omicron, I don't see why we wouldn't continue to produce other variants. And it brings back a very important question that I think no one wants to talk about. But are we creating the variants through immune pressure? And this was one of the conversations I had very early in the pandemic with Gerd Vanden Bosch. And he was saying that immune pressure would always produce more lethal or dangerous variants. Now, Omicron doesn't seem to be more lethal, but it's certainly more contagious. And so that could be a good thing, depending on what happens. If we all got mucosal immunity through Omicron and we were able to stop the spread of the virus, that would be a good thing. But it's yet to be seen, certainly with what's happening with the other variant. I can only think that it's continuing to reinfect people who were recently infected.
Could I throw a question in here from, again, the LinkedIn side? Is there any impact of the vaccines on, say, cancer growth?
Right. Who is trying to get me into trouble with these questions? What I would say is, I haven't spoken about this much in this presentation, but based on the research that I've been doing with autoimmunity, the primary cell that I think is affected with regards to a prolonged immune response, which could happen after a vaccine, is a macrophage. These are the immune presenting cells, and they're very, very important cells. If macrophages are being affected longer term, these cells are very important for tumor management, and they help to block tumors from growing and spreading. So if they become affected in some people, and even a small percentage, we could see a significant rise in cancers and metastatic cancer. And that's something that we all have to look out for. So there are many potential knock-on effects to what we're doing. And this is why it's so important for us to be very focused on the science and focused on what's happening, and be very nimble on our feet to change direction That's something that I think the politicians struggle with, because it's so important to maintain a message. It doesn't look good when you do a U-turn. But we are in times where we do have to be very nimble on our feet with regards to planning for the future.
Sorry, thank you. And one more question then on long COVID. Is that also autoimmune disease?
Yeah, well, long COVID is an area that I'm focusing a lot of attention on now. And rather than saying an autoimmune disease, I would say that long COVID is prolonged immune activation. And a lot of the research that I'm doing is suggesting that this is primarily triggered by the gut immune system. And so it is around an immune mediated reaction, but I wouldn't necessarily call it an autoimmune disease. I just say that the immune system is being overactivated over a long period of time, and this has long-term effects on people's symptoms.
Okay. But just following up on that question, in what cases then will it go to the lung? And, it doesn't always go to the lung, but it's just a bit of it that goes to the lung? Or, is it the extreme cases where it goes to the lung?
You mean to long COVID?
Yes.
Yeah, no, an interesting thing about long COVID is that long COVID is not necessarily related to the severity of the infection. So what I differentiate between COVID complications and long COVID. So
Okay.
COVID complications are a person who's had severe infection. They may have been on intensive care, or they may have been on a lot of high flow oxygen. There's damage to their heart or damage to their lungs because of the infection and the inflammatory response. And those people then have shortness of breath afterwards because of the organ damage. I consider that to be a COVID complication. I don't call that long COVID. Long COVID, however, tends to have a specific pattern with regards to fatigue, headaches, ongoing general, just feeling unwell. And that's different. And that can happen to anyone, even if they have a relatively mild infection. And so one of the arguments that is being put forward with regards to the benefit of vaccines is that the initial work, as they're saying, is that it seems to reduce the impact of long COVID. No, that's ongoing research. It's not absolutely clear, but I don't think that would be the indication to use a vaccine. But it could be a side benefit of using a vaccine, is that it could reduce the risk of long COVID in people who subsequently get an infection. The important point that I usually say to people is that people who get long COVID, in my clinical observation, usually have had gut problems before. That's all I would say without explaining that further. That's actually a course that I'm going to put together to explain long COVID and explain why people, or how people can identify the things that are relevant that would reduce the risk and help them to understand the disease.
Dr. McMillan, there's a question here in the chat on hair loss as one of the effects of COVID, but do you have a chart that just sort of has a number of other common long COVID symptoms?
I think I do actually have a chart. I think I just added it on to the end of the presentation. I think you can see it here. So yes, this was a paper that was done, is long COVID an autoimmune disease? Well, that wasn't what the paper said. They were just talking about long-term effects of COVID-19. I don't know how well you can see this, but the most common symptom, 58% of people had fatigue, 44% had headaches. I'm looking carefully. I think it was about 23% had taste and smell abnormalities. I think hair loss is in there, but I'm struggling to see my image closely enough. 1 second, let me just look at it. Yes, 19%. Yes, 19% had a cough. 24% had shortness of breath. 19% had joint pains. So you can see how many symptoms people have with regards to long COVID. So whichever way we take it in the pandemic, we are going to have a huge challenge with the impact of long COVID, the morbidity associated with COVID-19. And that's something that we really need to also find solutions for. And this is part of the reason, again, why I keep on focusing and highlighting autoimmunity. You cannot understand long COVID if you don't understand the autoimmune principles. It will just make no sense. And so this is part of the reason why I think it's so important for people to focus on education. I think everybody needs to be responsible to learn as much as they can about the disease so that they know how to manage it in their own lives. There's a lot that can be done just through lifestyle. It doesn't require necessarily a prescription.
Can I get a clarification on this? Because I thought when you said long COVID, it meant you meant LUNG,
Oh,
the
yeah.
COVID that goes into the lung. I mean, when people
Yes.
have that lung issue. But I
Okay.
realized it's LONG. What
Yeah.
is the difference between LONG, long COVID,
Versus
and
lung.
COVID?
Okay. So lung COVID, or the way to think of it is in the first two waves, when the virus very quickly spread to the lungs,
Right.
what was very interesting from the asymptomatic study is that even though people didn't seem to have many symptoms, they had subclinical inflammation in their lungs. Okay. It usually resolved on its own in a short period of time. That's within about 10 to 14 days. They have a little bit of cough, temperature, didn't really have much shortness of breath, and then they'd feel fine, and the lung changes clear up within about 2 weeks. Now, the important differentiation is that in severe COVID-19, it's not the virus that's damaging the lungs. That's really important to get. It's the immune system trying to attack the virus that damages the lungs. And that's why I mentioned the point about an autoimmune disease. It's actually the antibodies, the T cells attacking not just the virus, but the ACE2 that then damages the blood vessels in the lungs, causes inflammation in the blood vessels. And what actually kills people in COVID-19 are microthrombi, little clots in the blood vessels. And because of the inflammation, they can't exchange oxygen with the blood. And so somebody will end up on intensive care on 100% oxygen with a ventilator, and we still can't keep their oxygen levels up. And that can only happen by blocking the blood vessels in the lungs. It's kind of like if you've ever heard of a pulmonary embolus. It's like that, where the blood just is not able to go through the areas of the lung that have oxygen. So that's the primary thing in COVID-19 that causes severe disease.
Okay, and that's what the vaccine would be helping to prevent, actually, really, why they will encourage us to take that.
Yes, so what we have seen is significant reduction in people being on intensive care who have been vaccinated. And so the vaccine can't effectively stop infection, but it can make a big difference with regards to getting sick in hospital. So let me make an important point on this.
Yeah.
I think that one of the things that I have been pointing out is that we have been advocating vaccination without targeting vaccination. I am not sure if that is necessarily a wise move, meaning that we have to be careful with any intervention because we don't know long-term risks. But for people who are at risk of severe disease, that's people who have comorbidities, older people, people who are overweight, absolutely. That's how we will drive down the risk of severe disease. And it's a gamble that is worth taking because you're not so concerned about long-term effects if you're going to end up in intensive care on a ventilator, if that makes any sense. And so in that respect, it makes perfect sense. However, what we must be careful about is that if we don't know long-term effects, we have to be very targeted so that we don't potentially put people at risk for other potential complications. And that's a really important point, and something I have been saying over and over again. I would challenge anybody who says that you vaccinate the whole population. I would challenge them and say, we know who is high risk. We know who can be treated. We know where to target the vaccine. And there are so many places in the world that have not yet had a vaccine. How can we justify not giving the vaccine to countries that need it? That to me doesn't make much sense. But that's my personal opinion, and I'd be happy to challenge anybody on it.
Okay. Lily is asking, is there a test that can be done to know if you have had COVID in the past? And she thanks you for this informative seminar.
Yes, I mean you can test to see if you have IgG antibodies to COVID-19, but I'll put in a proviso there. There are many people, and sometimes it's up to 80%, 70 to 80% of people could have COVID-19 with almost no symptoms.
Mhm.
And so if you had no symptoms, it's unlikely that you triggered a significant systemic immune response. That means that the antibodies in your blood would rise. You would have triggered a mucosal response. And so what can happen is that if you only measure the systemic response, you may think that someone who has previously had COVID-19 didn't have it because they don't have IgG antibodies. As yet, we don't have good tests to test for IgA antibodies to COVID-19. That would be the ideal to know if somebody had been exposed. But it's possible, and maybe our researchers and scientists would be able to highlight that some more.
And following up on that question, are the current tests then that we're doing, the antigen tests, truly testing whether we have COVID-19? Not in the past, but
Correct.
presently.
Yeah.
Somebody does a test today, and is it really testing if I have Omicron?
Omicron, yes. It truthfully is not my area of expertise with PCR tests and so on, but what I've seen so far is that certainly the BA2 variant is very difficult to detect by our standard PCR and lateral flow tests. And so many people will test negative, but they could be positive. There is no easy answer for that because, again, a lot of people have very few symptoms. And this is probably part of the reason why some countries have taken the approach of just saying, you can't stop it. Don't worry about it. Let it go.
Okay, and Sharon asked, how long should you stay in the sun to get the required amount of vitamin D?
Well, again, it depends on where you are in the world. So if you're in a temperate climate, it only works in a very narrow window in the summer period. And it's between, I think, when the sun is directly overhead. So that may be between about 11 to 2, probably in a temperate climate. You need about 15 to 20 minutes in the sun. So if you are in the north of North America, that's a very tiny window.
But you can get that from some food as well.
Yes. And this is why it's good practice. And important point, the reason I highlighted skin color is because if you have very pale skin, so that's person, I guess the pale person with red hair, they are high risk for getting sunburns and for getting skin cancer. But they also have the advantage that they are 5 times more effective at converting sunlight into vitamin D. If you have very dark skin, you need a lot more sunlight in order to get the same amount of vitamin D. And that's why in a temperate climate, we just need to accept that we probably just need to supplement with vitamin D.
Wow, really great information. This has been awesome. I think I've covered all the questions on my list. Jackie, was there anything else on your list, on your side?
Well, Philip, maybe you could just check the last couple of questions coming in on LinkedIn. Would a D-dimer test be wise to pre-test for microclotting?
Yeah, well, the D-dimer test. So the D-dimer test is a test that we use to look for fibrin fragments and so it indicates that there is a clot. Um, it's relevant in more severe disease, but not for people who have mild infection. So, but if you are having somebody who is more severely unwell, truthfully, that's a call for the hospital. They should be in hospital, not checking their blood tests at home. So I don't think it's anything they have to worry about. But in hospital, the D dimer, the rising, is a significant marker that we could be having more microthrombi, and the person will probably need anticoagulation.
And there was one other question about interferon. Is there
Mhm.
anything more you want to say about the importance of interferon?
Yeah, interferon is a very, very important signaling protein. I think I actually have a slide here with regards to interferon. It's like a warning system or like a smoke alarm, so it picks up the smoke, sets off the alarm so you know to leave the house. So when a cell is infected, it produces these little small proteins called interferons, and it spreads to other cells and is kind of like knocking on their window saying that there's a fire, time to get out. So the cells switch off making protein. And it's the most important immune defense that the body could have, because it slows the viral infection down and allows the body time to get T cells and B cells with antibodies to stop the virus. Now, it's relevant because of interferon autoantibodies. In severe cases, they found that 10% of these cases had interferon autoantibodies. What that means is that they had antibodies that would bind the interferon and block it themselves. I think this is very, very important, because what it means is that this group of people are more vulnerable to the virus evading their innate immune system and spreading to the lungs. And this is why this would be relevant. I'd taken some time and looked at interferon autoantibodies. And again, this is something that I think is strongly correlated to gut problems. So people who have lots of symptoms with their gut, and this is something again that I intend to cover in that course, is explain to people the importance of not underestimating gut symptoms, bloating, diarrhea, constipation. If that's a normal part of your routine, the IBS picture, it suggests that you probably will have an overactive gut immune system. And if that is the case, you could be one of those people who have interferon autoantibodies. That's just my research looking into that. So it's not something for somebody to worry about. I just say, as a routine, people need to be aware of their body and thinking carefully about what we put into our body.
And a question on treatments. Is there anything you can say on the success of early treatments where it is being used?
Well, again, this is something that has been disappointing in terms of the response across the world. I think that we've put all our eggs in the vaccine basket, and we haven't listened to enough people who have been using early treatment protocols across the world. And the principles are very simple, is that patients, at least in the first and second and third waves, were getting unwell at about day 11. And it was very, very consistent. And this is some of the work that Dr. Shetty in South Africa noted. He describes it as the day 8 scenario, where exactly 7 days after their first symptoms, they would get unwell. This was an incredible clinical observation. And his strategy was to use high dose steroids with antihistamines. And he has saved all his patients. And so there are other people who use different systems in different parts of the world, but they haven't been given enough of a voice to hear. There's been the discussion about ivermectin, which has been completely discounted, certainly in the first world and in the Western world. And it's one of those situations where what have you got to lose? I have little interest in people who say it can't work because they don't understand the disease. When you understand that this is an immune mediated disease, any drug that impacts on the immune system has the potential to reduce the severity of the disease. Why would you not try something that has very low risk? Almost is what I call a banker in medicine. You have nothing to lose. But that's, again, my personal opinion.
Thank you. And the question on, should RNA vaccines be considered a form of gene therapy?
You know, I think that one of the biggest, the saddest things that to come out of the pandemic is the criticism that we have had of the mRNA vaccine technology. Now, I think that this is going to be one of the most important breakthroughs in terms of how we manage diseases going forward, certainly other viral infections. My research, however, suggests that they just may have picked the wrong disease here in terms of COVID-19, because everything that you would want it to do, it does. It produces a strong immune response. There are limited side effects. It's relatively easy to make and replicate. And so it has tremendous potential for many other viral infections. I just think in COVID-19, what we've done is we've missed the primary pathophysiology, because this looks as though it's an autoimmune disease. Almost any vaccine that you use would have some issues connected with it. And that's where I think I wouldn't argue about the issue of whether or not it's gene therapy and so on. I think that it has great value for many, many diseases that we're struggling with at the moment. And what I would not want to happen is that we throw out the baby and the bathwater. We need to take it for what it is. It has been a tremendous breakthrough, tremendous success on many, many levels. But we are just caught in a very unusual disease that requires us to think about it in a different way, I think, scientifically.
I think Dottie's asking a question here, probably as we wrap up. 3 minutes.
Yes.
If the antigen test is negative after 5 days, would that mean that the body has cleared the virus?
It depends again on how effective the antigen test is, because as we said with Omicron, the body it's not as efficient at detecting the viral particles, and so again, that is a call that is way above my expertise and pay grade. I will leave those experts to make their decisions on whether or not that's the appropriate thing to do. But again, the principle is it doesn't look as though we can stop Omicron anyway. So if the person is feeling better and they need to be at work, I think we probably will just have to accept that.
Wow. This was so informative. I really thank you on behalf of all of us that listened. And definitely going to be sharing this. Looking forward to the recording. And also, we're hoping that you can come and share with us about the, there was another one, dementia. What's the term again? Dementia.
Dementia.
Yes.
Dementia, yes. That was the next one. I know you had that as a topic, and really thank you so much, Dr. McMillan, for doing this.
Thank you very much. I'd like to say thank you to my audience that's been listening. I appreciate they've had so many questions, but it was hard for me to bring them up because you wouldn't have seen them. But I really appreciate everyone for listening and putting in their thoughts and their ideas. I hope this was useful to everyone. And again, thank you very much. And you can't see this, but I'm just going to do an outro video for them so that until the next time when I'll be able to speak about some other things in the next week. So thank you all to my audience on social media, and I hope this was of value, and we'll be in contact again soon.
Thank you.